All right. Well, hello, everybody. Welcome to University Hospitals Health Services Research Center Grand Rounds. And my name is Trygve Dolber. I'm a psychiatrist here and the medical director of personalized care. And it's my pleasure to introduce Dr. Gina Kruse. Um, Before I do that, though, a little bit of housekeeping. So this webinar is being recorded. It'll be available for you to view from the UH Research and Education Institute website. Please remember to mute your microphones throughout the presentation. If technical assistance is needed, please contact the R&E team, Nicole Bollinger or Abigail Zona, who are on the call. If you want to ask questions, you can type them in the chat. Questions can be seen by all attendees, and you have the option to submit them anonymously if you prefer. Okay, so Dr. Kruse is a physician researcher in the Division of General Internal Medicine at the University of Colorado School of Medicine. She trained in internal medicine and primary care at Mass General Hospital, completed a Harvard Medical School General Internal Medicine Research Fellowship, earned her MPH in clinical effectiveness from the Harvard T.H. Chan School of Public Health, followed by a postdoctoral fellowship in cancer prevention from the Harvard T.H. Chan School of Public Health Department of Social and Behavioral Sciences. Dr. Kruse's research uses clinical trials, observational research, and mixed methods to test interventions and examine implementation strategies to improve the delivery of preventive services with a focus on improving tobacco cessation treatment in healthcare settings in the US and internationally. And with that, I'll give it over to Dr. Kruse.
Thanks so much for having me. Thanks for the introduction. I am going to get set up with screen sharing here. It should be the slideshow. Okay. So it's a pleasure to be here today. What I'm looking forward to talking with you about are a couple of different elements of clinical trials in tobacco cessation that are really designed to tailor the intervention to better fit the individuals we're interested in supporting with their tobacco. I do work in cancer prevention, but my real focus and passion is around tobacco cessation. So those are the examples we're going to use today. We're going to talk a little bit about adaptation of interventions when they're developed in one setting, have demonstrated evidence in one setting, and we want to pick them up and use them someplace new. And what we did in one particular study that used a US-based intervention and adapted it for use in a low and middle income setting. And then we're going to spend the second half talking about adaptive treatment models, where adaptation focuses on sort of modifying that intervention to better fit, to be relevant for a new population. Adaptive treatment models combine evidence-based treatments over the course of somebody's quit journey, for example, and although we do this for other conditions too, to meet their needs as they change over the course of their treatment. And so we're going to sort of have those two halves of the talk. Okay, disclosures and funding sources, some family financial interests, some current grant funding, and the sources of some of the grants and studies I'm going to reference today are listed. So the agenda, we're going to start with a little introduction to the state of tobacco cessation treatment for those who aren't familiar with tobacco cessation treatment. Not going to spend too much time on it, but just lay a little groundwork for what evidence-based treatments we have at our disposal, what are the guidelines, and then we're going to dive into those two pieces, like how do we adapt interventions that use these evidence-based treatments to meet the needs of a new population, focusing on a cultural accommodation process. And then two, how do we combine these treatments into adaptive treatment models so they can evolve with the individual as their needs change during treatment? So level setting with tobacco. Tobacco is a hugely important public health issue. It's the leading preventable cause of death. At least 480,000 Americans die each year from tobacco, which by comparison in 2020, there were recorded 385,000 COVID deaths, and yet tobacco is rarely considered a public health emergency. Globally, there are an estimated 1.1 billion people who smoke and 8 million smoking attributable deaths per year. So this is both a US and a global problem. In terms of volume of tobacco use in the US, 18.7% of Americans report using any form of tobacco. It's about 46 million people. And in terms of conventional cigarettes or manufactured cigarettes, which are the ones that have the most research and evidence base for treatment and documented harms, are conventional cigarettes. 11.5% of Americans report current cigarette smoking. That's about 28 million people. And so I remember, just for background, I just moved from Massachusetts to Colorado, as my bio probably suggests. And I remember getting to Colorado and people saying, well, why would you move to Colorado and want to do tobacco research? It's not a very high prevalence state. But even here, the prevalence is pretty close to the national average. And that means 1 in 10 people are smoking cigarettes, which are incredibly harmful substances that on average shorten people's lives by 10 years. And so it is, while the prevalence is declining, and that may lull people into saying this isn't the big public health issue that it used to be, it really still is. It's still 1 in 10 people. It still is a leading preventable cause of death and should be treated with some urgency and priority. However, the other element of tobacco that is really important to understand in our current epidemiology is that even though that prevalence is down to 11.5% from a level around 50% of the population in the 1950s, this incredible decline, that decline has not been even. And so tobacco is increasingly concentrated in specific groups and increasingly disproportionately harming those specific groups. So to give you a few numbers, socioeconomic status measured as things like being uninsured or a recipient of Medicaid, having low educational attainment, those populations smoke at 2 to 3 times the national prevalence. Rural residents use tobacco at higher rates. People with psychological distress, people who report disability, and some sexual orientation minorities, LGBT populations smoke at reported higher rates than heterosexual or straight populations. So the burden of tobacco is increasingly concentrated in groups that may face other barriers to care and health inequities. So what do we have to do to address tobacco in both those populations and the general population? Well, we have effective treatments, and our last U.S. Public Health Service guidelines were updated in 2008. So there hasn't been a lot to add to the evidence base of FDA-approved medications and treatments in the last 15 years. But we have rich evidence base for tobacco cessation. We have behavioral support through counseling, individual group phone counseling, and some evidence for mobile health interventions, behavioral interventions. We have pharmacotherapies, and we know that using both together works better than either one alone. With the sort of like big picture on tobacco cessation is, of these evidence-based treatments, more is better, but even brief intervention works. That's the take-home point. So how do we think about this in a little more detail? Well, one, as we're thinking about those treatment offers, it's important to think about why people keep smoking as you design a treatment plan to meet their needs. And there's really 2 elements to why people keep smoking. One's the pharmacologic addiction to nicotine. So those factors that describe addiction, needing to use more nicotine to get the same response, experiencing withdrawal symptoms when you're not taking in nicotine. And there's also a psychological dependence on smoking, things like behavioral cues, like smoking after a meal or a cup of coffee, or using it as a coping means for coping with stress, coping with emotions. So when you're thinking about treatment, you both need to address that pharmacological dependence and withdrawal symptoms, and you need to think about the behavioral or psychological dependence and supporting people to deal with both of those as they try to quit. So this is a very busy slide. I don't intend you to read it all. It's meant to highlight a couple of things. So when we think about the 2 sort of buckets of treatment that we have to both help people with that psychological dependence and the nicotine withdrawal symptoms, the behavioral treatments are there to help with psychological dependence. And it comes in lots of flavors. So this table is here demonstrating a long list of behavioral interventions that have demonstrated efficacy, mostly of at least moderate certainty of benefit. So this is now hundreds of trials, thousands of participants that show that behavioral treatment delivered as simple brief advice, which is just a few minutes, physician brief counseling, nurse delivered counseling, even printed self-help materials, telephone counseling, group, which is things like the state quit line, group counseling, individual counseling, text messaging, internet-based interventions, and financial incentives all have evidence that they work better than either a minimal care control or a placebo. or no intervention to help people quit smoking in terms of achieving long-term cessation. The one I skipped over there is mobile phone apps. At the time that we sort of put this together, there was very low certainty that there were any mobile apps that had demonstrated that they could increase long-term cessation compared to control condition. But since then, there actually have been some publications of randomized trials demonstrating long-term cessation benefit from some mobile apps. And so this is probably a little out of date, and that's probably something we're going to have to increasingly add to our list of behavioral treatments that we can offer people. To put this in a little bit simpler language than that very busy slide, that's meant to show, like, gosh, there is a ton of evidence showing this stuff works. The things to think about at our disposal are in-person counseling. So if your health system has either tobacco treatment specialty service or providers themselves can deliver this counseling, it is effective. Telephone counseling is especially appealing because it's available through all 50 states through the quit line, and actually available in many countries. Many countries have adopted quit lines, national or regional quit lines that offer multi-session counseling. Many of them also offer other resources and services. So things like being able to mail out nicotine replacement therapy. In Colorado, our quit line has partnered with our state health department so that they can actually mail any of the FDA-approved pharmacotherapies out to patients to quit line callers who receive Medicaid. So they can just mail them their meds as part of that quit line service. Mobile health interventions I mentioned here, I'm lumping together both text messaging, which actually has a pretty robust evidence base that it can increase long-term cessation, and then this newer evidence of we're starting to get some apps that seem to show that. Printed self-help materials are super easy to put into your office to make available for your patients, and believe it or not, compared to no intervention, they work. They're not our strongest intervention by a long ways, but gosh, for something as important as quitting smoking, putting a few self-help materials, making those available to people has an effect. And then there's also interactive internet-based interventions. So these are websites where people can enter information and interact as they go through and try to quit. So there's some resources through things like our smoke-free text website offered by NCI. So a lot of things that we have to choose from to meet people's needs. Now, how about what is the state of our pharmacotherapy for tobacco cessation? Well, we have a set of first-line treatments that basically come in kind of two flavors. There's nicotine replacement therapies, and then there's the prescription medications, the tablet-type medications. Nicotine replacement therapy comes in two forms. There's long-acting skin transdermal nicotine, the patch, and then there's short-acting forms that can be a gum, a lozenge, an inhaler, or a nasal spray, a little plastic inhaler. It's not the e-cig, it's a little prescription plastic inhaler. And those are, the short-acting form works by its sort of slow onset level of nicotine and a steady dose of nicotine over the day, and it's meant to prevent withdrawal symptoms in people trying to quit. The short-acting forms, the gum, the lozenge, the nasal spray, those are meant to provide some fast onset nicotine, not quite as fast as a cigarette, but they're pretty good. They get on board within minutes to address cravings in the moment. The pharmacotherapies we have are bupropion, which is actually an antidepressant, but has demonstrated efficacy for smoking cessation. It's the bupropion SR form that we use, and varenicline, which is our most effective single agent pharmacotherapy, which is a partial agonist medication. And so it works by sort of two mechanisms. One, that varenicline binds to the alpha-4 beta-2 nicotinic acetylcholine receptors. And by doing that, it reduces withdrawal symptoms because it's partially binding to that receptor. At the same time, it blocks, as you smoke while you're taking varenicline, because that varenicline is blocking those receptors, you don't get as much reward from smoking. And so it kind of has two modes of action. And I see a raised hand.
You have your hand raised. I'm not sure if that was by accident or you're trying to ask a question.
Sorry, it's my mistake. It's arrow. I didn't mean it.
Okay. And the Zoom sometimes catches you like doing a thumbs up and does it too.
I apologize.
No problem. So that's what we have on available to us. These are all FDA approved for tobacco cessation. There is evidence of a few other medications promoting tobacco cessation, but these are the only three with an FDA indication for tobacco cessation, for cigarette cessation. And similar to our behavioral table, this big number filled table. You're not meant to read it all, but it's meant to highlight, gosh, we have these kind of 3 free classes. And again, thousands of participants, lots and lots of trials, high certainty of benefit. We typically say they roughly double your chances of quitting, except for varenicline, which maybe does a little bit more than doubling. And if you combine 2 forms of that nicotine replacement therapy, that can work almost as well as varenicline or comparably well to varenicline. And that's meaning using the patch plus a short-acting form to prevent withdrawal and have something to deal with cravings. So that's the state of the treatment landscape. So how are we doing with connecting people with these evidence-based treatments? So in the US, we know that most people who smoke cigarettes want to quit. On the order of like 2/3 of people say like, yeah, I am now interested in quitting. I want to quit cigarettes. And that has been pretty steady over time. This bar graph shows from 2000 to 2015, reports of self-reported interest in quitting and receipt of these treatment services. So all the way left, most people are interested in quitting, and most of them translate that into action and make a quit attempt in a given year. So a little more than half of people who are smoking try to quit in the past year. That's usually defined as intentionally not smoking for a day or longer because you're trying to quit. So people want to quit, they're taking action. But that middle bar that's very, very low there, those are the number that achieve success. So less than 10% achieve smoking cessation when they try to quit. So add that on. So not a very high success rate. Well, hey, don't we already have all these evidence-based treatments? But the problem, there's a bit of a treatment gap. So as people are interested in quitting and trying to quit, the rate of use of these treatments aren't that high. And we as a healthcare system are not doing a very good job of supporting them, or as good a job as we could. I shouldn't say not a very good job. There's room for improvement. So if we ask people how, if they received advice to quit from a health professional in the past year, if they saw a health professional in the past year, and it's not quite 60% say they did. So there's some room for improvement there. Like we should be advising people to quit every time they interact with the healthcare system because it's such an important issue. And then the next step is like, well, how many of them use any evidence-based treatment, either behavioral or pharmacologic or both? And that's about 1/3. So there's a pretty big treatment gap between these effective, safe treatments, sometimes free, treatments if you count the quit line, and whether people are using them when they try to quit. So there's a treatment gap. So how, as we think about this, and the treatment gap is not just US based, this is US based data, but there's treatment gaps that we can see in other settings as well. So now with that foundation, we're going to dive into the first part of this, which is thinking about adaptation. And so adaptation, we're talking about, let's say I have a behavioral intervention, like a counseling intervention or a telephone counseling intervention that's been studied in one setting, demonstrated efficacy, and I want to use it in a new population that hasn't really developed its tobacco cessation treatment services. What do I have to do to make it relevant and work for that new population where the evidence base was somewhere else? Well, we probably have to make some modifications. We probably have to adapt it to make it relevant to that new setting. And so the obvious example is, and I'm going to give you an example here, so I'm going to start with that one, is let's say I have a behavioral intervention that's been developed and tested in the US for tobacco cessation among people with HIV, which is another one of those populations that has continued to smoke at higher rates than the general population. And because most people who smoke and most people with HIV don't live in the US, they live in low and middle income settings. How do I pick up that evidence-based intervention that we developed like in New York and make it work somewhere else, like India? Well, we have to do some amount of adaptation. At a minimum, we need to change the language, but there's probably also other cultural adaptations that we need to change to make it work in that new setting. And the key is really to consider both what you need to sort of change the form of for cultural relevance, language access, things like that, but still maintain the function of that intervention. So it still mechanistically works how it's been demonstrated to work. The degree of adaptation that you have to do to a given intervention and may vary depending on how different the new population is from where it was originally tested. But luckily, we have a lot of frameworks to support adaptation processes. And so I'm going to give you, show you how we applied one of those to adapt a behavioral intervention for tobacco cessation tailored for people with HIV and culturally adapted it for a population in Chennai. So we use this framework, there's lots of these, and they have a lot of common features. We use this one called the cultural accommodation of substance abuse treatment. We need to change the language to be a little less stigmatizing, but this is the name of the framework that we used. It's got these stages of adaptation. One, you sort of like pull all the information you have together about what needs to change about the new population to know, like get some sense of how we need to modify and change things. 2, you go through this accommodation practices, which makes the content fit the context and the delivery setting. 3, you pilot test the content with your population of interest, and that sets you up for a randomized trial. We selected this particular cultural adaptation model because they've used it for tobacco cessation interventions before. So we use this framework to adapt something called Positively Smoke-Free Mobile. I am not the developer of Positively Smoke-Free Mobile. Positively Smoke-Free Mobile was developed by John Shooter in partnership with partners at University of Michigan's Center for Health Communications Research. Positively Smoke-Free is a set of social cognitive theory-based behavioral content that's been tested by John and his collaborators in lots of different forms, in person, in groups, by telephone, and this mobile version. And we opted to adapt the mobile version for use in India for a couple of reasons. One, they have over 1 billion mobile subscribers, and data rates are the cheapest in the world. So it seemed like a really good option that was likely going to be scalable and accessible to people because of that high penetration of mobile phones. The other reason we partnered with India is we had some established relationships with partners in Chennai and knew a little something about their population at this particular site, Voluntary Health Services Infectious Disease Medical Center, the Chennai Antiviral Research and Treatment Clinical Research Site. Those are our India-based partners. We had done some preliminary data and knew that the prevalence of current tobacco use among patients newly presenting to their clinic for HIV care was 37.6% back at the time we were doing the prelim data. And that included both smoked and smokeless users, as well as people that use both. So there's substantial prevalence of tobacco and widespread mobile phone access. Beyond the VHS IDMC clinic, we also know that India is an important site to think about tobacco and tobacco control. It's home to an estimated 275 million tobacco users. And we had done some work elsewhere in India looking at the treatment gap, that's sort of that bar graph that I showed you earlier. And so we had done some work with a Mumbai hospital where we found 16% of adults admitted reported current tobacco use, smoked or smokeless. Around half have made a past year quit attempt, very similar to the numbers I showed you from the US. Most people believe that quitting would improve their health. And 71% reported that they were asked about their tobacco by a doctor, but only 4% had used any evidence-based treatments in prior quit attempts. So really highlighting there's an opportunity here to connect people with those evidence-based treatments to support them to quit tobacco, this very harmful substance. So with that in mind and those partners, we are currently recruiting or actively enrolling in what we call our MOVie trial, Mobile Behavioral Support plus Varenicline in India to End Tobacco. It's a 2-arm hybrid type 1 implementation effectiveness trial where we are comparing 2 treatments with evidence-based efficacy of promoting long-term cessation among people with HIV compared with a standard care control that adheres to the WHO's Framework Convention on Tobacco Control's recommended standard of care, which is screening for tobacco use, offering brief advice, and connecting people to treatment. In this case, they have a regional quit line. So let me tell you just a little bit more about that rationale. I'm not going to talk too much about the hybrid implementation effectiveness trial here. I'm sure you're going to have some great speakers in the series who talk a little bit more about implementation science. I really wanted to focus on like how we set ourselves up to be able to do this. The implementation stuff comes later in the process. So our trial is designed as just this 2-arm trial. We're recruiting from our partner site at VHS. We're recruiting adults who are there for HIV care, who are currently smoking, and can safely take varenicline. And we developed the intervention in 3 languages that account for the most of the language preferences of the population they serve there, which is Tamil, Telugu, and English. We're randomizing 400 people, 200 to the standard arm, which is that brief advice and linkage to the national quit line, which is available in those local languages, versus this this more intensive treatment arm, the study treatment arm, varenicline plus positively smoke-free. So we had to set ourselves up to be able to offer positively smoke-free in that intervention arm through this adaptation. We're looking at long-term cessation outcomes. But just wanted to give a little bit more rationale leading into that positively smoke-free adaptation. So we chose this intervention based on that, that guideline and that recognition that offering behavioral plus pharmacotherapy support should work better than either alone. And so to have a robust, comprehensive cessation program, we should offer both. And so varenicline was the medication we chose because it's the most effective single agent pharmacotherapy for tobacco cessation. And it also, at the time that we were proposing this, was the only one of that list of pharmacotherapies that had demonstrated long-term efficacy in a placebo-controlled trial among people living with HIV. And that was based in France. So it seemed like a really good choice for a medication that people living with HIV should have access to if they're smoking. The other thing is important to this population. Varenicline has demonstrated efficacy for cessation of cigarettes and smokeless tobacco. And I showed very quickly showed you that data that about a third of people who are smoking in this clinic population are also using some form of smokeless tobacco. So having something that can help you quit all forms of tobacco, varenicline is our best choice. And then finally, as we were proposing this, the patent protections for varenicline were expiring in 2020. And so we thought, hey, this is going to be really timely as more generics come on the market. This is going to be a medication that's increasingly accessible in low and middle income settings. And of all the places to start making this available in low and middle income settings, India was high on our list because of their robust generic pharmaceutical manufacturing industry. So as we were thinking about how to make this varenicline plus positively smoke-free fit in the clinic population, one, we had to think about how we were going to get the varenicline into that protocol and integrated with the behavioral support. One, we found some generic manufactured varenicline that's manufactured in country and available at a low cost. We thought about sort of how to develop our protocol to integrate those two pieces. We thought about with varenicline, you can start it before your quit date, and there's increasing evidence to show that that's safe and potentially effective to start it even sooner, like a few weeks before your quit date, as opposed to just 1 week, which has been the original format. And so we developed the behavioral support to account for that option of quit dates. And then we also knew from prior work that when varenicline hasn't worked in studies of people with HIV to quit smoking, people often attributed that to insufficient adherence. And so we wanted to make sure we embedded some adherence content into the behavioral support. So the original positively smoke-free that had that evidence base behind it didn't necessarily have the varenicline adherence bit. It was developed in partnership with people living with HIV in the US, developed in New York, and pilot tested. This is sort of a screenshot of the original version. Again, like I am not the developer of this. This is something we just said, hey, here's an evidence-based intervention. We want to test it in a new study. It's a theory-based behavioral intervention based on social cognitive theory. And we thought at the time, it was the only behavioral treatment that was shown to increase cessation at 6 months among people with HIV. This tailored, positively smoke-free that comes in, again, these many different forms. You can do it in person, group, mobile. We chose the mobile form for India because of that mobile prevalence in India. Some prior work had demonstrated that mobile options may be preferable to populations living with HIV in terms of behavioral support, and may even work better. Some systematic reviews suggested that. And we also knew that positively smoke-free, the content itself, was adaptable because some of the in-person forms had been adapted for other global settings. And so we thought the content's adaptable, mobile's a good choice here, and some data at that time had even suggested it may be preferable. So we took that positively smoke-free mobile version, the content, and we went through this adaptation process to make it fit the needs of this trial and the patient population of interest. To go through, I'm going to tell you about the first 3 stages because stage 4 right now is the trial, which is enrolling. The first 3 stages took us about 4 months. And this is sort of a different view, but still with those 3 stages. The first one being sources of information. So in stage 1, we had the original scripts, and it's delivered through a set of messages and videos. And it was originally SMS delivered messages with links to these videos that walked you through this program. So we had the scripts for the videos and we had the message content. And we started to gather sources of information about communication methods based on our experts on the ground, or our partners on the ground, our experts in the content on the study team. And we also had some preliminary data, a little snapshot of that I showed you on a prior slide. So we knew a little something about tobacco use patterns and treatment approaches in that setting. And so with all that information and the expert input, we took those original positively smoke-free drafts and of messages and video scripts, and we started to make modifications and adaptations. We changed cultural references. We added that smokeless content to align with local practice. We actually changed the delivery mode, the model, from SMS to WhatsApp, because WhatsApp is what they used for clinical communications with their patients. So it's a their WhatsApp delivered messages with links to the videos on the mobile website. And with that change in the system, they also brought in a UDX designer to weigh in on user experience. So all that, we got a new draft with sort of a first round of cultural adaptations to make this to India. And then we shared those drafts with providers and counselors working in the clinic to review the draft content and weigh in on further modifications that were needed to fit within their workflows and their context. And so that yielded modifications on things like, well, you know, where it says to distract yourself when you're having a craving by sipping some water or tea, like don't say tea, because tea stalls are actually a really common place to smoke. And for that list, you know, when you're advising people to go to a smoke-free setting, tell them to go to a temple, because that's a smoke-free setting that is more widely used than some of the ones that were listed in the original draft. And you don't have enough references to family, because in our care system, in our context, family is a big part of motivation for health behaviors and a big part of the care process. So you need to talk about family more. And so the development team considered all those changes and worked with the local team to get the right vernacular and generate three language versions. That was the point where we went through and translated the content based on those first two stages. So we now have the Tamil, Telugu, and English version of the messages and the videos. And then for stage 3, we did the initial testing. And to do this, we shared those versions with pilot focus groups with focus groups to pilot test the content for each language. And that generated another set of changes. So the patients who reviewed that in the focus groups suggested things like using meditation to distract yourself during cravings, emphasizing self-kindness, because this is a hard thing to do, more tips for dealing with cravings in the moment. So some of those tips to go through a smoke-free setting, to go to a temple, are fine. But if you're having a craving right now, it takes a few minutes to get there. What do you do now? They also weighed in on sort of the format of the videos and things like that, some of which we could respond to and some of which we couldn't, but we did our best to respond to everything that we heard that we could. The other thing is that even gave us an opportunity to weigh in on some of the workflow, and they in particular wanted to emphasize risk of HIV disclosure, to how to consider that in the consent process. The messages didn't say anything about HIV, but the video content, which you had to sort of log in and use, did have content. And so really making sure people knew that was going to talk about smoking among people with HIV. Their biggest criticism was that this is a text-based, a lot of the messages are delivered by text. And so we were leaving out a segment of the population who with different literacy levels. And so that was their major critique about inclusivity, is wanting to think about modifications that could reach that group as well. So in the end, it got us to the set of videos. These are still shots of some of the videos in Tamil and Telugu, and some of the WhatsApp messages that go out with, and you can see the link to the video that goes back to deliver this theory-based message that's now adapted for Chennai that we are currently testing. Have to do a little shout out to the team, because this has been just a real group effort here. So my team, our grant here in Colorado, does the data coordination. The team on the ground in Chennai is listed there at CRS and IGMC and pictured. We have partners at MGH who do some different elements of the trial, like some cost effectiveness analysis. We have John Shooter on the team, who is the original developer of the positively smoke-free content, and his partners at the University of Michigan, Larry Ahn and team. And then we also have some consultant from Harvard School of Public Health, Dr. Rush, for the cost effectiveness, which I'm not talking about today, but it's a big collaborative team to get this process started. So that's an introduction. So that's one approach to taking something that's been tested in another setting and tailoring it to meet the needs of a new population. So the sort of next part of this, how do you make an intervention that better meets the needs of your population based on evidence-based pieces and parts from somewhere else, we're next going to talk about adaptive treatment approaches. Adaptive treatment models are models where we start with the treatment regimen and then we modify it based on how the user responds to it. We do this in lots of chronic diseases. This isn't something that should sound very new for any of the clinicians in the room. This is how we treat hypertension and depression. We start with what the evidence tells us should be the most effective intervention for most people. You start there, you check and see if their blood pressure is where it needs to be. And if it's not, then you switch or you increase the dose or you add another medication and then see, check for response there. But it hasn't been used in tobacco. We just haven't had the data to do this. The typical tobacco model is that you come in for your visit, we ask you about tobacco use. And as I pointed out, we don't even do a great job at that. We ask you about tobacco use, we offer you treatment. If we're doing a really good job, we might follow up with you, but we really don't have any data to tell us, well, when that treatment isn't working for somebody, what do we do then? And these adaptive models and increasing evidence base are starting to generate some data around how we should do that, how we should modify treatment to meet people's needs as they go through their quit journey. Adaptive treatment models in tobacco cessation are, sort of at the center of this is modification based on treatment response. Key to that are a few different elements. There's lots of considerations as you're thinking about an adaptive model. One, when do you check for response? Is it better to check early to get people onto a different, more helpful medication or stronger medication when the first one isn't working? Is it better to check a little later after they've had a chance to try it out and give it a little bit of time to see if it's going to work? We don't really know, but there have been models that have tested different timings. Pre-quit assessment of response, you start your medication and can you reduce your cigarettes? Post-quit response, trying to catch relapse early and modify your treatment regimen. People have looked at different intensification options, sort of those things I mentioned that we do for hypertension, right? We either switch, increase, or add. And there's a couple of models that have demonstrated efficacy that looked at adding a new class of medication to a first treatment, another one that increased the dose of the first treatment for people in relapse. And we're going to talk about those just a little bit more. So those get into, there's pre-quit adaptive pharmacotherapy is really based on the idea that there's an increasing recognition that starting medications before your quit date can be helpful. A month beforehand is typical, so that people can start to get the hang of the medications, know what's working, start to reduce their cigarette use. The medications can start to reduce their urges to smoke, their enjoyment, because of the way those medications work to address withdrawal and really set people up for success when they get to that quit date. So mechanistically, there's this very small literature showing like that this probably will set people up. And so if we know that we've done a good job getting them through that pre-quit medication, they're going to be more likely to succeed later. This is a really cool study that leverages that idea. Some of the mechanistic data is based on NRT. This study actually used a kind of very real world relevant model of starting people pre-quit on their choice of medication, NRT or combination NRT or varenicline, those sort of like two most effective pharmacotherapies. And then 2 weeks into their pre-quit period, they checked to see if they had reduced cigarettes. And if they hadn't, they added on another class of medications, bupropion. And if they had, they continued with what they got. And this was actually placebo controlled. So that group got a placebo as well as continuing on their original medication. They also had a standard care arm to show whether this adaptive treatment worked better than what standard treatment would be in their tobacco treatment services. They were recruited, the patients here were recruited through a tobacco treatment service at an institution. And they found that the adaptive arm was associated with higher rates of cessation at end of treatment. And that adaptive arm, again, was starting on their choice of medication. And then if they hadn't reduced, adding bupropion. And that was associated with post-quit treatment success. Yeah. In the post-quit models, this is the idea of like catching relapse early. So this is the model that was a trial that was done in Texas. And for this model, they randomized people to either varenicline or NRT. They didn't use the choice here, but they had those two first-line medications. And then at 6 weeks past, they started 1 week pre-quit, which is the sort of traditional pre-quit amount of time for varenicline. You can also start pre-quit NRT. So they got a week pre-quit, and then they started in on their quit attempt. And if 6 weeks after their quit date, they hadn't quit, then they tried 3 things. They either said, well, continue it, because the typical treatment is that you just continue it for another 6 weeks for a full 12-week course of treatment. They switched it. So if you were on varenicline, you got combo NRT. If you're on combo NRT, you got varenicline, or you increased the dose. So if you were on varenicline, which is typically dosed at 2 milligrams a day, they increased to 3 milligrams a day. If you're on nicotine combo NRT, your patch was 21 milligrams a day. They went up to a 42 milligram a day patch. And they found, this is because of the complexity of this trial design with those 3 different characteristics, they had end of treatment cessation for these different combinations. And they found that the increased dose in both arms appeared promising and was associated with higher quit rates than the folks who continued their base therapy, which would have been sort of like the typical standard care where you just send somebody out with 12 weeks of medication. The NRT arm, the switch to varenicline, also appeared to show some promise. So one of the things that I think this trial in particular is anybody's thinking about adaptive trial designs, there is some real complexity in thinking about how you design and interpret these because of all the moving parts and the different combinations people can have, and making sure you really understand what your comparators are and what you're testing. And just to give you like one more little example of this over just a couple minutes, is I have some pilot trial data where we studied an adaptive intervention that used a slightly different approach than these pharmacotherapy adaptations. In this pilot trial, we like the idea of a stepped care model where you start with something that's kind of low intensity for people who may not be ready to dive into multi-session counseling, which both of those prior adaptive examples had multi-session counseling for everybody in addition to this pharmacotherapy adaptation. So starting out with something that may be a better fit with somebody's preferences than diving right into a intense medication plus counseling program. Maybe you start with just some text messages, which have evidence of effectiveness, are going to work for a handful of people, very safe, convenient. Most people like getting text messages. And so starting out with this sort of step care where you can prioritize something that more people might be willing to engage with than that really intensive treatment program, and then escalating when people need more. So a few people are going to find success with texting alone, but when they need more, we can start to get them into more behavioral and pharmacotherapy support. This was set up as a pilot trial, so we didn't get definitive outcomes, but it was so useful for us to set up as a pilot trial to get to the hang of that question of like, well, what are we really comparing? And so we were trying to test the feasibility of comparing 2 different times of assessment of response, and then what we escalated to for people that needed more help than the SMS. And so we were comparing 4 versus 8 weeks assessment of response, and then whether we just sent them some NRT or we sent them some NRT plus some telephone coaching. This was set up as a SMART trial, a sequential multiple assignment randomized trial. Not all adaptive interventions are tested with SMART designs. SMARTs are really intended to help you develop your adaptive trial that you might still need to go back and compare to a standard care arm. In adaptive interventions in these SMART design trials, we'd say there's sort of 4 elements you need to think about. And there's some really nice papers that have been written about the methodology here. One is the decision stage. It's like, when's that assessment of response element? What are the treatment options? Like, what are you going to offer people as their needs shift? What are you going to tailor things to? Like, what in the study we used an intermediate tailoring variable, which isn't like, did they quit at 6 months, but like what's happening during this treatment? There's an intermediate variable that can help inform a decision. And then the decision that you make at that decision stage is what are you going to offer people based on that tailoring variable? And so we set up this trial where we, the decision stage was for 8 weeks. The tailoring variable was whether somebody had reported they had quit for the past 7 days at that 4 or 8 week time point. And then if they hadn't, we offered additional support and we randomized to 2 different additional support options. It's published as a pilot. Part of the driver for this is really just meant to say part of the driver for this SMART design was that we had initially just tested SMS plus mailed nicotine replacement, like text messages plus nicotine replacement together like a forearm trial where we had text messages, we had NRT, we had both. And it was promising, but qualitatively we heard from people that they didn't totally fit together. Like they got the text, they got the meds, but they weren't totally sure how they fit together. And so we thought maybe something that was adaptive, a step care model, might be a more logical sequence for people to engage in. So this is another busy slide. And it's to that point about like when you're setting up these adaptive trial designs, really thinking about what your comparators are. This is meant to sort of highlight that. So we had two randomization points here. One was, did they get R1? Did they get early or late assessment of response? Like 1 week into the treatments or 8 weeks into the treatment. And then R2 was whether when they needed more help, did we give them just some text messages or did we give them NRT in addition to continuing text messages, or did we also give them some telephone coaching as well? But you can see like you get people in all these different paths through this with those two randomizations and the different treatment escalation options, where if you're responding, you get one thing, but then your non-responders get randomized again. And if you have 2 rounds of randomization, you end up with 6 groups at the end. We actually didn't have 6 because we didn't have any responders at our 8-week trial. This was a small pilot's feasibility study. We had 35 people, so we didn't get anybody through this one pathway. But when you go on to compare it, then you have to recognize, okay, so I can compare the addition of NRT versus the addition of NRT plus coaching, and I can pool them across my early and late assessment of response. You have to understand that that's another variable there that may vary, that you're sort of combining those two groups together. You can also compare your early and late assessment of response, but know that there's a whole lot of different paths through that people in that early response assessment are getting. And so sitting down and thinking about your comparisons and your analysis in these is really important. I've definitely seen some like papers come in for review where it wasn't totally clear that the comparison they're able to achieve made a lot of sense. So just to finish this up, I often do some qualitative work, particularly in pilot studies, to understand how it went. People generally liked this sequential approach in terms of like making them feel supported and that they knew the steps to take. Recruitment happened during COVID, which was challenging, but we could do it fully remote. Retention was excellent. Satisfaction was excellent. And when we talked a little bit about, well, did this seem to work better than we just sent everything all at once? People really did like the combination of programs. They felt it, they supported each other. I don't think it was directly the text messages, but those reminded me that I was going to be talking to you, and it definitely helped me. And then people talked about, by the time I got to the coaching, which is like after randomization too, I'd had some success under my belt. And so I knew what I was struggling with, so I could discuss them. And so talking about the benefits of that. So a bit of a whirlwind introduction to some promising adaptive designs, to a little peek at smart designs and how we can make these interventions that really shift to meet people's needs during the course of their treatment. And with that, I wanted to make sure I left a little time for Q&A. And so that is the last slide I plan to present. And I'd love to take any questions, comments, reactions.
Thank you so much, Dr. Kruse. That's you ended exactly at 11:48 with exactly 12 minutes, so I can tell you've done this before. And that is a lot of information packaged really neatly in a small time frame. I'm going to leave an uncomfortable amount of time of silence for people to come up with questions. It is a little bit of an intimate group today, so don't feel like there's hundreds of people listening to your question.
So, sorry, Craig, can I ask a question or do I type it over there?
You may ask it. I'm monitoring the Q&A, the chat,
Okay.
and you can also unmute yourself to ask one.
Thanks, Gina. Great presentation. I really enjoyed it. And I just have a few, very basic questions. How transferable these trials are? Means, you presented this in tobacco cessation, but can I take it to the NICU for something very different? And for, let's say, breastfeeding, I don't know, something like that. How this whole concept of using mobile-based technology, how transferable they are from one clinical condition to other, or one setting to other, and even one country to another.
So there's a couple of, I'm gonna respond for both the sort of mobile health adaptation we did and then also that adaptive trial design there. For the mobile health adaptation, I think so that, certainly there's a lot of mobile health research in lots of different settings. And I think how transferable some of the content is probably depends a little bit on some of the underlying conceptual model, causal models, and theories that drive behavior change. I mean, if you can show, hey, I can promote self-efficacy for this thing through this model, which is kind of how a lot of text messaging and mobile health interventions for tobacco work is often through self-efficacy. There's also some elements of people feeling sort of like social support from those messages, which is weird because it's usually totally automated, but they really do. So to the extent that those factors are mechanisms relevant to your health behavior, I would think this is a model you could translate to a new thing, but you'd certainly have to test it if it's a whole different behavior. But if there's a shared mechanism there and there's similarities in terms of how people use and interact with that and think about the communication mode, that's the other thing. It's like, are people willing to communicate about this thing through this mode? Are there privacy issues? Or, are they mobile users? So I think there's some elements to consider, but I would think that there's transferable elements. And I think for tobacco specifically, right, like whether text messaging that's been tested in the UK also will work somewhere else, the answer is like probably. There's some shared behaviors there and probably some shared mechanisms, but you certainly need to think about the adaptation to make it locally relevant. And the key there, there's such a need for research that tells you how much adaptation is enough, right? Because like if you just translate it, that's not going to be too expensive, make it really scalable. Can you do that? Would that be enough? And I think in our case, it wouldn't have been, because we still would have told people to like go check baseball scores as they were, trying to reduce a craving, which just didn't make sense in that, like, isn't culturally the right fit. So, but it's so informative to know, well, how much do we have to invest and spend on that adaptation to make it work here? And there's such a need to know like how much tailoring is enough and how much that tailoring impacts its effectiveness. Like if we do like just enough, will it work as well? Or if we do a better job, will it work better to really justify that extra investment and really making it culturally fit? The other part was, so I had these two models, right? There's the adaptation of the thing for a new setting, and then there's the adaptation within an individual's course, the adaptive designs. I think the adaptive designs probably make sense in a lot of particularly, they've been widely used in chronic disease in particular, things like diabetes, hypertension, depression management. This is how we do all of those things. And we just haven't had the data in tobacco yet. You start with something, you check and see if people are responding, and then you give more if they're not adequately responding to what you start with. And we just haven't had the models to do that in tobacco, but I would anticipate that same kind of model would work in other settings. And so if it's a population where maybe like they're maybe reluctant to engage in very intensive treatment for something, some of that step care idea where you start with something that's convenient and low risk, that might be enough to start with engagement, and it might help a certain number of people, and then you escalate or offer more for the people that are now engaged but clearly need more because they have tried and haven't succeeded with just that very light touch intervention. So hopefully I answered the question.
You
There's a
did.
lot of
Thank you. No, that's really helps, and thank you.
Mhm.
And there's a question in the Q&A, but I'm going to try and piggyback selfishly off the one Sam just asked, because I had a question about that same kind of idea. I remember this Melinda Gates talk from years ago where she was talking about public health interventions and taking a cue from Coca-Cola, where they would market based on happiness. And so they would say, all our ads, we want to portray happiness while someone's holding a Coke, and we're going to figure out how do people define happiness in their culture, and that's what's going to be going on when someone's holding a Coke. And so their underlying concept was kind of happiness. Is there a way, and you're kind of alluding to this already, is there like a formal way, or do you think it would be interesting to develop a formal way to look at those kind of stage 1 and stage 2 cultural adaptations and say, hey, we ended up changing this from one culture to a next, but it still worked. What was the underlying kind of, as with self-efficacy, what was the underlying concept that's the general element that we can then easily adapt to other cultures just by seeing, hey, what's your culture's take on self-efficacy without having to go through a lot of extra steps?
Yeah, that's interesting. So let me see if I can think about that, and then I'm going to get to that Q&A question about vaping. So usually in implementation science, there's this approach where you really want to recognize as you're modifying something for a new setting, some evidence-based treatment, you think about the key functions and the different forms that that can take to fit this new setting. And so you might want to, like, I usually think about sort of starting out with, well, if the, you know, the way we think mechanistically this works is by building self-efficacy. We have to make sure that self-efficacy content stays in there. And then we, you know, build the different forms around it, like we delivered by WhatsApp instead of SMS. But that what you're bringing up is also like, well, does even that core concept of self-efficacy, how is that defined and represented from place to place? And that's really interesting. So it's not just sort of like the package and the delivery that happens around it, but even like what that core mechanism might vary from place to place. I don't know how much research we have on that. That would be super interesting to think about how some of those like mechanistic things are represented differently and leveraged. So I don't know if we know, but I think it's pretty interesting. I mean, there should be some common phenomenon to some of those mechanisms of behavior change, right? So just understanding the language around that is sort of like changing the form in which it's delivered. But yeah, it's really interesting. But I often sort of, as I'm starting out, think about that form and function implementation science dichotomy, where like this is something that can take in different forms and it's not going to change the way this works. It's just going to fit within this new setting. But the way this works is the part we can't change. Otherwise, it won't be this intervention. And then is it really implementing an evidence-based intervention? Is this even the same evidence-based intervention if we change some of those core functions? So we, for example, we really worked hard to maintain the content, the behavior change content in the original Positively Smoke-Free, even though we like totally re-recorded the videos. Just wanting to make sure that we were using that evidence base, leveraging that evidence base and making it fit this new setting. Yeah.
Thanks. And then we have a couple minutes left for Esther's question about vaping.
Yeah, so these are timely topics. We know a whole lot less about how to help people quit vaping than we do about how to help people quit cigarettes. And there's a couple of things to think about, and I don't have time to go into all of them because that's like a whole nother talk on its own. The interventions I talked about were focused on smoked tobacco. As I mentioned, in India, they were smoked tobacco plus smokeless tobacco. So India actually has banned e-cigarettes, so e-cigarettes are not widely used there. But it was meant to help people quit all forms of tobacco. So that was actually a little bit of a modification where we expanded what we were trying to get it to do, to not just quit cigarettes, but to quit all forms of tobacco. There is a growing evidence base for how to help adults quit vaping. We have one new medication that looks poised to be the first FDA approved cessation medication for vaping, not approved yet. And so that's not quite there, but there's also been now a handful of trials that show that things like varenicline can work for adults to quit vaping. In terms of youth and the younger population, there's even less. And there's a few trials ongoing now studying medications for youth to quit vaping for those under 18. There are text messages that work, a text messaging program that's been demonstrated in RCTs to help youth. I think some of the concept we talk about in terms of like adaptive treatment would be super interesting to study in that population. But it's interesting because it's a population where we don't have that very hefty evidence base to lean on like we do for helping adults quit smoking. So I can like move around and combine all these different evidence-based treatments I have for adults to quit smoking because I know so much about their safety and even how they can be combined. And we just don't know as much about youth. But that idea of the step care model maybe has some particular potential there if maybe our either providers or youth themselves are a little reluctant to dive right into something like varenicline. Maybe you start with some of the behavioral things that we know work, like the text messaging model. And then for people that don't respond to that, you think about escalating to something else to help folks quit. I think there's some potential there, but there's not a lot of data.
Thanks. And there's another question also about, oh, well, I guess you incorporated that one in there, the e-cigarettes among younger populations. It's 11:59. Anyone have any quick last questions? Okay, that's about 7 seconds. So thank you so much, Dr. Kruse, for the lovely talk and the thoughtful answers to our questions and making the time to come here. And thanks everyone else for coming. And hopefully we'll see you again in a couple weeks.
Thanks so much.